Outlines. Competence. Culture competence. Culture competency. A historical lens. Why is culture competence important? What is health disparity? Concepts of diversity. Social identity. Diversity in the context of health. Dimensions of diversity. Risk factors. The distinction between disease and illness. Culturally incompetent healthcare setting. 5 elements of cultural competence. The process of culture competence in the delivery of healthcare services. Edward T. Hall's culture iceberg model. Competence. Competence implies having the capacity to function effectively as an individual and an organization within the context of the culture, beliefs, behaviors, and needs presented by consumers and their communities. Culture competence. One is culturally competent when one possesses the cultural knowledge and skills of a particular culture to deliver effective interventions to the members of that culture. Culture competence in healthcare describes the ability of systems to provide care to patients with diverse values, beliefs, and behaviors, including tailoring delivery to meet patients' social, culture, and linguistic needs. Culture competency, a historical lens. Dr. Carter G. Woodson may have introduced the concept of culture competence in 1927 when he put his life on the line to create the Society for the Study of Negro Culture and Life, and instituted Negro History Week, the precursor of Black History Month. This effort to promote cultural knowledge was a precursor to our culture competency work. Culture competence. Cross et al.'s definition recognized the connection among the individual, organizational, and structural applications of culture competence (CC), and that CC can be applied on 3 levels. Individual refers to individual knowledge, skills, values, and behaviors. Organization refers to an organization's management and operational framework and practices, including policies, procedures, mission, vision statements, planning, documents, services. System. Every organization works within a border system, for example, territory, state, federal system, with its own standards, legislations, regulations, and infrastructure. Why is culture competence important? Culture competence is important because it reduces disparities in health services and increases detection of culture-specific diseases. It addresses inequitable access to primary health care. It impacts health status of culturally diverse communities. What is a health disparity? A health disparity is a difference in rates of illness, disease, or conditions among different populations. Disparity not only means difference but also inequality. This means that there are differences in health outcomes for some groups compared to the outcomes of the general population. It's important to understand that there are some factors that contribute to these differences that are unavoidable and cannot be changed, and some that are avoidable and can be changed or affected by individual actions, society, or system changes. Age and race are individual differences that cannot be changed, but behaviors and actions can be changed. System changes can also be made to allow more access to preventive and primary care. Understanding how all risk factors contribute to health disparities, particularly for the patients you see, can help you become a more culturally competent provider. A health disparity is a particular type of health difference closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual or gender orientation, geographic location, or other characteristics historically tied to discrimination and exclusion. Health disparities and health inequities are terms denoting important differences in health status among socioeconomic, racial, and ethnic groups. Disparities in healthcare are defined as differences by race or ethnicity in access to or the quality of healthcare that are not due to the health or clinical needs or preferences of the person. Well documented health disparities exist. For example, blacks have nearly twice the rates of low birth weight infants and infant mortality as whites. Concepts of diversity. Diversity is a subject phenomenon created by group members themselves who, on the basis of their different social identities, categorize others as similar or dissimilar. A group is diverse if it's composed of individuals who differ on a characteristic on which they base their own social identity. Ludin and Rosner 1991 define diversity as that which differentiates one group of people from another along primary and secondary dimensions. Social identity. The term social identity refers specifically to those aspects of a person that are defined in terms of his or her group memberships. Although most people are members of many different groups, only some of those groups are meaningful in terms of how we define ourselves. In these cases, our self definition is shared with other people who also claim that categorical memberships. For example, as a woman, as a Muslim, as a marathon runner, or as a Democrat. Diversity in the context of health refers to the numerous ways in which individuals and groups differ in their beliefs, behaviors, values, backgrounds, preferences, and biology. Diversity is most often described in terms of language, culture, ethnicity, and race. Each of these aspects, along with biological diversity within the human population, has health implications. Dimensions of diversity. Primary dimensions: race, ethnicity, gender, age, disability. Secondary dimensions: religion, sexual orientation, geographic origin, family status, economic status, political orientation, work experience, language, culture, thinking style, lifestyle, education, nationality. Tertiary dimensions: beliefs, assumptions, perceptions, attitudes, feelings, values, group norms. Risk factors. Risk factors that can contribute to health disparities include poverty, acculturation, a bilinear process occurring with respect to both the new and the heritage culture. A series of changes in culture mores, ideas, words, values, norms, behavior, institutions, resulting from direct and continuous contact and interaction between groups of different cultures, particularly through migratory movements or economic exchange, the media, and other channels. Behavior and lifestyle, nutrition, access to healthcare services, genetic predisposition, education level, discrimination, differing levels of insurance coverage, access to high quality networks of preventive and primary care. The distinction between disease and illness. Although the terms disease and illness are systematically synonyms, culture anthropologists and culture psychiatrists make an important distinction between them. Disease is taken to refer to the medical definition of sickness by professionals and is explained from the perspective of biological and psychological etiology, patterned clinical manifestations, course, and outcome. Disease is considered objective and universally similar in nature. In contrast, illness refers to the patient's psychological construct of the perception, experience, and understanding of suffering. Illness is subject and open to cultural impact. For instance, a man suffers from epileptic seizures. A physician conceptualizes it as a medical disease. From the patient's point of view, the seizures is an illness that may occur suddenly and may or may not interfere with daily behavior. It might be interpreted as a minor annoyance, or it might be interpreted as the result of a force imbalance in his body, a temporary position of an evil spirit, or the consequence of an ancestor's immoral behavior. Disease. From the perspective of the doctor, it's a disease that has an underlying biological pathology. Illness. From the patient's perspective, it's an illness that's experienced subjectively by each patient. Sickness. Society and culture's perception of the illness is one of a sickness that tends to breed specific emotions around the illness, especially for the patient. University of Toronto notes Cross-Culture Interviewing, a Guide for Teaching and Evaluation. Toronto, ON 1969. Three perspectives: disease, sickness, and illness. Illness: a person's subjective experience of their symptoms, what the patient brings to the doctor. Disease: underlying pathology, biologically defined. The practitioner's perspective: the illness seen in terms of a theory of disorder. Sickness: social and cultural conceptions of this condition. Culture beliefs and reactions such as fear or rejection. These affect how the patient reacts. Also covers what is considered a disorder suitable for medical treatment. Culturally competent healthcare setting. Culturally competent healthcare setting should include an appropriate mix of the following: a culturally diverse staff that reflects the community and communities served, providers or translators who speak the client's language or languages, training for providers about the culture and language of the people they serve, signage and instructional literature in the client's language and consistent with their culture norms. Culturally specific healthcare setting. 5 elements of culture competence. Individual level. Acknowledge culture differences. Understand your own culture. Engage in self-assessment. Acquire culture knowledge and skills. View behavior of self and others within a culture context individual. The process of culture competence in the delivery of healthcare services. Compina Packet, 1989. It's a model that views culture competence as the ongoing process in which the healthcare provider continuously strives to achieve the ability to effectively work within the cultural context of the client, individual, family, community. This model requires healthcare providers to see themselves as becoming culturally competent rather than already being culturally competent. Assumptions of the model. Culture competence is a process, not an event. Culture competence consists of 5 constructs: culture awareness, culture knowledge, culture skill, culture encounters, and culture desire. There is more variation within ethnic group than across ethnic groups, intra-ethnic variation. There is a direct relationship between the level of competence of healthcare providers and their ability to provide culturally responsive healthcare services. Culture competence is an essential component of rendering effective and culturally responsive services to culturally and ethnically diverse clients. Culture awareness. Culture awareness is the self-examination and in-depth exploration of one's own culture and professional background. This process involves the recognition of one's biases, prejudices, and assumptions about individuals who are different. Without being aware of the influence of one's own culture or professional values, there is risk that the healthcare provider may engage in culture imposition. Culture imposition is the tendency of an individual to impose their beliefs, values, and patterns of behavior on another culture. Culture knowledge. Culture knowledge is the process of seeking and obtaining a sound educational foundation about diverse culture and ethnic groups. In obtaining this knowledge base, the healthcare provider must focus on the integration of three specific issues: health related beliefs and culture values, disease incidence and prevalence, and treatment efficiency. Obtaining culture knowledge about the client's health related beliefs and values involves understanding their worldview. The client's worldview will explain how he or she interprets his or her illness and how it guides his thinking, doing, and being. Culture and illness behavior. Illness behavior refers to how patients think, react, and cope when they suffer from illness. It includes how they perceive and understand their sickness, seek help for their health problems, utilize healthcare systems, and how they benefit from healthcare. In contrast to this, health behavior refers to how people behave to maintain their health. A patient's illness or health behaviors are subject to individual factors such as education and past experiences, as well as culture factors, and these elements may need to be recognized to properly understand the patient. Culture knowledge. Disease incidence and prevalence among ethnic groups is the second issue the healthcare provider must address when obtaining culture knowledge. This requires obtaining knowledge concerning the field of bioculture ecology. Disease incidence varies among ethnic population, and healthcare providers who do not have accurate epidemiological data to guide decisions about treatment, health education, screening, and treatment programs will not be able to positively impact on healthcare outcomes. For example, Afro Caribbeans have higher rates of sickle cell anemia than white Europeans, but less rates of hemophilia. Culture knowledge. Treatment efficacy is the third issue to address in the process of obtaining culture knowledge. This involves obtaining knowledge in such areas as ethnic pharmacology. Ethnic pharmacology is the study of variation in drug metabolism among ethnic groups. In obtaining culture knowledge, it's critical to remember that no individual is a stereotype of one's culture of origin, but rather a unique blend of the diversity found within each culture, a unique accumulation of life experiences, and the process of acculturation to other cultures. Therefore, the healthcare provider must develop the ability to conduct a cultural assessment with each client. Cultural skill. Cultural skill is the ability to collect relevant cultural data regarding the client's presenting problems as well as accurately performing a culturally based physical assessment. This process involves learning how to conduct culture assessment and culturally based physical assessment. Linger 1978 defined a cultural assessment as a systematic appraisal or examination of individuals, groups, and communities as to their culture, beliefs, values, and practices to determine explicit needs and interventions practices within the context of the people being served. Cultural skill is also required when performing a physical assessment on ethnically diverse clients. The healthcare provider should know how a client's physical, biological, and psychological variations influence her ability to conduct an accurate and appropriate physical evaluation. Examples include differences in body structure, skin color, visible physical characteristics, and laboratory variances. Cultural encounters. Culture encounters is a process that encourages the healthcare provider to directly engage in cross cultural interactions with clients from culturally diverse backgrounds. Directly interacting with clients from diverse cultural groups will refine or modify one's existing beliefs about a cultural group and will prevent possible stereotyping that may have occurred. However, healthcare providers must be aware that interacting with just 3 or 4 members of a specific ethnic group will not make them an expert on this cultural group. It's possible that these 3 or 4 individuals may or may not represent the stated beliefs, values, or practices of the specific cultural group encountered by the healthcare provider. This is due to intra-ethnic variation, which means that there is more variation within a cultural group than across cultural groups. Cultural encounters also involve an assessment of the client's linguistic needs. Using a formally trained interpreter may be necessary to facilitate communication during the interview process. The use of untrained interpreters, friends, or family members may pose a problem due to their lack of knowledge regarding medical terminology and disease entities. This lack of knowledge can lead to faulty and inaccurate data collection. Culture desire. Culture desire is the motivation of the healthcare provider to want to, rather than have to, engage in the process of becoming culturally aware, culturally knowledgeable, culturally skillful, and familiar with the culture encounters. Culture desire involves the concept of caring. It has been said that people don't care how much you know until they first know how much you care. It's not enough for the healthcare provider to merely say they respect a client's values, beliefs, and practices, or to go through the motions of providing a culturally specific intervention that the literature reports is effective with a particular ethnic group. What's of grave importance is the healthcare provider's real motivation or desire to provide care that's culturally responsive. Culture desire includes a genuine passion to be open and flexible with others, to accept differences and build on similarities, and to be willing to learn from others as culture informs. This type of learning is a lifelong process that has been referred to as culture humility. Edward T. Hall's cultural iceberg model. In 1976, Hall developed the iceberg analogy of culture. If the culture of a society was the iceberg, Hall reasoned, then there are some aspects visible above the water, but there is a larger portion hidden beneath the surface. What does that mean? The external or conscious part of culture is what we can see. What does that mean? The external or conscious part of culture is what we can see and is the tip of the iceberg and includes behaviors and some beliefs. The internal or subconscious part of culture is below the surface of a society and includes some beliefs and the values and thought patterns that underlie behavior. There are major differences between the conscious and unconscious culture. Internal, implicitly learned, unconscious, difficult to change, subjective knowledge. External, explicitly learned, conscious, easily changed, objective knowledge. What can we do? Holt suggests that the only way to learn the internal culture of others is to actively participate in their culture. When one first enters a new culture, only the most overt behaviors are apparent. As one spends more time in that new culture, the underlying beliefs, values, and thought patterns that dictate that behavior will be uncovered. What this model teaches us is that we cannot judge a new culture based only on what we see when we first enter it. We must take the time to get to know individuals from that culture and interact with them. Only by doing so, we can uncover the values and beliefs that underlie the behavior of that society.